It seems to me like I'm always grateful for the same things, like the health and happiness of my family or something like that. But today I'm going to be telling you that I am grateful for every single one of you who has come out on a Saturday in the rain to not only hear what we have to say, but for us to be able to show you how committed we are to the betterment of care for patients with neuroendocrine within the entire southern region. So I am grateful for the people that have come from Baton Rouge, the people that have come from Florida, that people have come from Texas, we've got Arizona, and I just think it's a real sort of testament to the draw that this program gets for some of the things that we're trying to achieve. So I am grateful for every single one of you. Now I will tell you that wellness is also about work-life balance, and so the fact that you guys are all here on a Saturday instead of, like, I don't know, doing other things that are supposed to be wellness, you can bring that up with your therapist, because evidently it's okay. So I was just going to go right in because Marianne wasn't here this morning, so I'll go right into my talk if you want. So we were just going to start. Now you're going to have to tell me how I do the... Oh. Or, Mary, you can stop pressing the button. But don't worry, I'm a better doctor than AV person. Okay, so we were going to go with the sort of the basics because I didn't have, so the one thing which is like one of those shows off Broadway, we have to say, oh, and this person is not going to be able to play that part today. And so Lowell Anthony got trapped in Charlotte, so he decided that to get trapped in Charlotte meant that he was just going to make a U-turn and go back to Kentucky. So we don't have anyone filling in for Lowell Anthony, but that there are other videos that are available on the NCAN site that would cover some of the clinical trial and the chemotherapy topics that he would. And obviously all of us as part of our program are more than capable of answering those questions, but that I will add just like a smidgen of that into this basics talk. Okay, so what I tell every single one of you, and you're going to be like, oh my God, is she going to go with that analogy again? So is that few cases are exactly alike. So you can go onto the internet and you go onto support sites and things like that, and you're trying to get information. And I think they are absolutely phenomenal for giving information, as long as we understand, and they do have a disclaimer, that no neuroendocrine case looks exactly like the others. So I think one of the take-home messages I want everyone to get is going to be that you're a unique patient with unique issues, and there will be unique relevance to some of the therapies that we offer. So another take-home message I want is that when you are then having a conversation with your physician or with a second opinion, you are understanding the key drivers. Doctor, what is the key driver in my case that is having you say that this medical decision is most appropriate? Understanding tumor grade and stage. I think that if you are a patient in our program and we haven't beaten into your head the importance of tumor stage and grade, but that I will go over it again. The pathology report does include important information, and I will usually tell people if you were to keep anything in your, I don't know, safe or files at home, it would be the pathology report that includes the important information. There are many treatment options. Another thing about our program that I think is somewhat different than other programs, we like to give you the whole menu of options, even when some are more or less relevant to your case, but just so you understand going into the diagnosis and treatment that there are a lot of treatments out there. They are not mutually exclusive. I would say that for the most part, neuroendocrine subspecialty centers will often use them alone or in combination. We have been very creative in some patients in how we would utilize this in order to achieve a treatment goal. When a second opinion matters, and that the talk that we won't be having today is the importance of clinical trials, but they are super important in rare cancers because oftentimes what you can get on a clinical trial is actually better than what we would potentially be able to offer you, but that it's not available outside of a trial. So identifying drivers of medical decision making, tumor grade, that is when you're looking under the microscope and you're looking at the number of cells, that are dividing under the microscope, and it tells us whether or not it is low grade, very slow growing, versus higher grade, more aggressive. You have a primary site. The primary site actually matters, and so the data that supports a lot of what we do is often going to be based on the primary site, even when we're dealing with a decision about metastatic disease. So you have foregut. It's going to include pretty much your head and neck, your esophagus, your stomach, your duodenum, and some of the other sort of neuroendocrine type stuff in that whole upper aerodigestive system. So that includes like your bronchopulmonaries that are predominantly within the lung. The extent of disease, is it in one site or is it in multi-sites? I will often tell people, just because I use the word multi-organ site involvement of the metastatic disease, it sounds so much worse than it actually is with respect to the treatments that are available, but it makes the relevance of some treatments more or less relevant. The treatment options are depending on those involved sites, the data that we have to support some of it. I'm going to talk about liver-directed therapies, and some of the data that supports what it is we do is going to be more or less relevant to the site of involvement. The SSR avidity, that's what we call the hotness on that PET scan, also super important, especially if we're trying to exploit the receptor as part of our medical treatment. So when we shifted from an Octria scan, of which I can almost count many of you who have lived long enough to have gotten an Octria scan and one of the gallium-68 or the copper, is that with the evolution of PET imaging, I think we feel a heck of a lot more comfortable that we are treating the extent of disease that we actually have versus what we think someone has. And then there will be other medical conditions that drive your ability to tolerate certain types of treatment. So in people with kidney disease, we have to be careful with liver-directed therapies. That's a contrast load. If you have heart disease, we can't lickety-split put you under general anesthesia and do a major surgical cytoreduction. So we have to balance out the types of other medical conditions someone have that would influence medical decision making in a disease where people live a long time, and you don't want it to be a trade-off of the current problem for a problem that you would then have to live with the rest of your life. So grade, they tend to go into dichotomies, low grade and high grade. So I think people understand the G1, G2. That's just this stain that the pathologist put on the thing, and they count up the number of cells that are trying to divide. It's like going back to, is it high school? Maybe even elementary school, you learn the mitoses. But it's a proliferation index. It's just saying how many of those cells are trying to divide compared to what you would expect with normal cells. So G1s and G2s are often lumped together. Do you want me to not do something? Okay. They're often lumped together because a lot of the outcomes are similar in G1, G2. But let's just be serious. We wouldn't have a difference between G1 and G2 if they were identical. So we may then have a slightly different discussion if someone's riding into the high G2s or the Ki-67s of around 20%. And then you have the high grade, of which are your G3s, intermediate, and higher grade. Those are the more aggressive histopathologic subtypes. They are more likely than not going to need chemotherapy over the course of a patient's lifetime. And then there is this category right here that is surprisingly one of the most debated and controversial categories at our national meetings, because G3 well differentiated oftentimes will shift towards the lower grade, and therefore some of those treatments are more appropriate, and sometimes they will shift towards the higher grade, and chemotherapy or some of the immune therapies may even be appropriate for them. So that there's a lot of the clinical trials out there are actually looking at that particular subtype in order to better understand whether or not like PRRT and things like that are going to be relevant for G3 well diff, and I think the answer is yes. So I just bolded those to say that we actually have these three categories are what we are mostly concerned about for these types of meetings, because the vast majority of the treatment options fall into those three categories, and then the higher grade are predominantly treated with chemotherapy. So additional information from your pathology report that has less to do with the treatment that we would choose, but does have to do with prognosis or the expectation of biologic behavior over time or local recurrence. So you have the primary tumor. So you've got lymph nodes in there. That's no different than lymph nodes. With a breast case, you take lymph nodes from the underarm. Colon, you take lymph nodes from the colonic mesentery. We take lymph nodes along with our primary resections. So you have a primary tumor, and then you have the lymph nodes. Well, the number of positive lymph nodes over the total number of lymph nodes that are removed kind of matters, because if you have 5 positive nodes in 6 lymph nodes that are removed, and you think about lymph nodes like a huge spider web within your body, it's hard to say that you took out 5 and then there was one little negative one over here, but you could have potentially missed something just outside of those 5. If you have 5 positive lymph nodes and 25 lymph nodes removed, oh, we feel pretty darn confident that your risk of local recurrence in that lymph node basin is low. So lymph nodes, the number of lymph nodes is the margin status. That is the margin status on the primary, whether or not that be a pancreatic primary, a bronchopulmonary primary, or a small bowel primary, is that if you have a positive margin, then your risk of local recurrence, because you will have microscopic evidence of disease at the margin, it's going to be higher. But that we have techniques that I think Dr. Boudreau is going to go over in his talk on how we can deal with really tight margins, especially when the tumors are growing in really tight areas where we can't get a really good margin. Unifocal versus multifocal. If you have a single tumor in the small intestine, choppity chop in the pan, you are less likely to have additional tumors form in the remaining small bowel than if you were to have 20 tumors in that same segment of small bowel. So multifocality is like looking at weeds on your lawn. If you have only one weed and you feel confident that you have one weed, well, you can dig it out, you can poison it to death, whatever. You're less likely going to have additional weeds over the course of the season. If you say, oh honey, we've got like 8 weeds on our lawn, well, the chances of being able to dig out all 8 weeds and know that you're not going to get another weed over the course of the season would just be naive. So multifocality sort of matters. Vascular and perineural invasion. Perineural invasion is more important in local regional recurrences because that's when the tumor cells, for whatever reason, are growing along nerves, and we can't really see that, so it's all going to be just kind of our gestalt on what that margin should be. And then the perivascular invasion means that there are at least some cells that have gotten into the bloodstream. Now, if you have metastatic disease at diagnosis, which almost 50% of people do, well then obviously the cat's out of the bag. But that if you have a primary and we remove all measurable disease, and that is in your path report, well, the reason why the guidelines go up to 10 years is because your risk, even with a slow-growing tumor, of developing metastatic disease is actually based on that component of your pathology report. And then the regional involvement, we do it based on the size of the lymph nodes. That's when you take in out a mesenteric mass. If it's greater than 2 centimeters, then that puts it into a different category of risk. And then obviously the evidence of metastatic disease. That's when stage comes into play. And that when we're talking about stage and grade, I will focus you on grade, because neuroendocrine is one of those diseases where the grade is often more important than the stage. So a low grade stage 4 can actually do better than a higher grade lower stage. The treatment options are not mutually exclusive. So other than chemotherapy down here, we have someone that's going to be, well, I'm going to go over this one because we don't have someone doing that, but I'm going to talk about liver-directed therapies. Kendra Harris runs our radiation oncology. She sort of took on our evolution of driving our alpha particle therapy, so she's going to talk about that. Boudreau's going to talk about surgery. I've got it split into pancreatic neuroendocrine, that's going to be Kristen Limbach, and the small bowel neuroendocrine, it's going to be Dr. Boudreau. And then, as I said previously, if any of your unique cases are questions about chemotherapy, it's just not covered because Lowell Anthony couldn't make it. So I really think it's important to just go over definitions because definitions are relevant in all cancer, even if you're not talking about neuroendocrine, but you're at a cocktail party talking about someone else's a cancer journey. So if we are talking about something being done with curative intent, it means that we are looking at a situation and saying, I believe that I can remove all measurable disease, whereby we are trying to eliminate this as a variable over the course of your entire life. So wouldn't it be great if we were doing every cancer operation with curative intent? Well, we would even, if you were to talk about some bad acting cancers, like a pancreatic cancer, for example, we still do those cases with palliative intent, even though it would be naive to think that still 90% of people with pancreatic adenocarcinoma will ultimately succumb to pancreatic adenocarcinoma. But that's when you're dealing with the biology of the disease and not the intent of the treatment strategy that you're using. So to do something with curative intent, meaning we are trying to eliminate all measurable disease. Now, there are some cases where you would be doing something with curative intent, even in the setting of metastatic disease. This program has gained enormous recognition nationally about our aggressive surgical approaches, whereby people will often live to die of something else. So I guess we can say that we do something with curative intent, meaning that we are trying to not have neuroendocrine be a driver of a patient's mortality. But palliative intent is actually super important too. Palliative intent means we are identifying some issue, whether or not it's pain, bleeding, perforation, the potential to grow into something that will cause you a significant problem over the course of your long life, or symptoms, carcinoid syndrome, diarrhea, flushing, lightheadedness, whatever it is. If we're doing it with palliative intent, we're trying to explain to you that we do not need to take out 100% of the disease in order to reach that endpoint. It's just that we're judging the success of our intervention on slightly different parameters. We aren't judging the endpoint on our ability to remove all measurable disease. We're judging it on the fact that, did the pain go away? Did the diarrhea get better? Did the flushing get better? Did it not grow into an area that would have made it very difficult to treat or cause a significant problem for which we do not have a good treatment? So that we will often talk to patients about the goals of treatment, and the goals of treatment in palliative intent is 100% reasonable in neuroendocrine. But I also want you to say is that we do things with palliative intent in almost all cancer subtypes as well. As long as we achieve the palliative intent goal, that would be successful. And then prolongation of life is really what all cancer therapy is about. So your investment in chemotherapy, that's when I deal with quantity of life over quality of life. So I would be saying, if we're going to focus on quantity of life, it's about everything that we're doing to prolong a life compared to if we were to not do that. So most of everything that we're doing is obviously trying to prolong a life. We would prefer to prolong it with palliative intent so that you can live the best quality of life. And oh sure, we would love for you to actually live to succumb to something other than neuroendocrine. And then this is my car and parking analogy, which for you guys, you're like, oh my God, is she going to do that car and parking analogy again? But that when I give these talks elsewhere, people are like, oh my God, I love that analogy. So when you're talking about, in particular, somatostatin receptor avid, meaning that you have that receptor on the surface of your cell type, a lot of what we do in neuroendocrine is either trying to target that receptor or trying to diminish the number of receptors you have so that then some of the treatments would be able to work more effectively. So if you imagine that you have an extent of disease and you've got, 1,000 receptors. So, and then you are trying to give a drug, that would be lanreotide. And what I tell you is that that's like injecting you with a bunch of little cars that are searching for that receptor / parking space. And like a police officer putting a boot on the car, it's trying to cripple the cell, keep it from spewing out the chemicals that give you carcinoid syndrome, but also mess with the mechanism by which that cell divides. So the main goal, kind of like the curative intent, palliative intent, prolongation of life, is that it is done with palliative intent. It can control people's symptoms very effectively. Oh, but after following people for a really long time, it delays the tumor growth over a long time, and it does prolong life. So that's why pretty much, the standard of care would be saying, hey, the easiest decision to make is to put you on this medication that is a standard of care and meant to not only prolong your life, but improve the quality of that life as well. So if you have a large disease burden and you've got 1,000 parking spaces and you're sending in 20 cars, I think you won't have enough boots on the car, and you will ultimately get that cell in some way, shape, or form to continue to grow. Whereas if we were to look at all of our treatment options as trying to either block the parking spaces or decrease the number of parking spaces, well then, if you can cytoreduce, if you can liver direct and kill tumors in your liver, then ultimately you will diminish that 1,000 to something that is more reasonable for the standard of care systemic therapy to work. So a lot of what we're doing is trying to decrease a tumor burden, whereby we are decreasing the total number of receptors / parking spaces that we need to control. This is my little boot on the car. Yeah, so the 5 issues this is my summary slide, the 5 issues that I think that we need to teach patients, and these advocacy groups teaches patients about being your own advocate, is that we need to understand priorities of care. So not in everybody's case, but in your case. If you are predominantly focused as maybe a younger person or someone that is still very much experiencing the richness of life, well then we may be going with prolongation of life and or whatever we can do to prolong that life with the best quality of life. Priorities. Is it palliation of symptoms, or is it active cancer treatment whereby we are trying to pretty much kill tumor cells? What are the unique drivers of medical decision making? Sorry about that, that's me. What are the unique drivers of medical decision making in your case? Not in your neighbor's case, not in the person on the internet's case, but in your case, that would be putting your case and the treatment strategies in perspective. Put multiple treatment options in perspective. I think one of the things that I'm very sensitive to when we're giving a second opinion is that someone will say, they told me I wasn't a surgical candidate. They told me it was surgically unresectable. They told me I couldn't get PRRT. They told me the chemo was my only option. And even though that all of those treatments may actually be true, if we don't explain to you why, in your case, something is more or less relevant, then I just don't think that we're actually doing a job. So I think at the neuroendocrine subspecialty centers, we are more apt to give you the whole menu, even if some of the options are not as relevant or not relevant at that point in time where we're making the decision. And then obviously we have tumor boards and multidisciplinary teams. That's the checks and balances of all of us, so you know that it's not just my opinion and my opinion alone, but that we need to really discuss it with radiation oncology, medical oncology, interventional radiology. Clinical trial opportunities, that's actually part of tumor board now. That's a sort of a requirement that we would make sure that we are either building a clinical trial portfolio that is relevant to the patients that we serve, but that we would also be discussing the relevance of those clinical trials at tumor board. And then we have a nutritionist here to tell us all the dietary and behavior modification that can help us with symptoms and the effects of treatment, and probably have all of us live a hell of a lot longer. And lastly, take-home messages. Treatment plans for neuroendocrine need multidisciplinary input. I think every single talk that you're going to hear on neuroendocrine is going to be how you really need all components of the treatment. I think one of our major concerns, especially in a part of the country that doesn't have a lot of resources, is that someone will be treated with something that a institution has, but that if they don't have everything, then they aren't then able to give you all of the options. So you need all of these people, okay? And I think in order to be able to address not only the cancer, but the non-cancer related side effects, the side effects of treatment, you really need to have that multidisciplinary team. The team should have all disciplinaries giving complementary recommendations, not that one person has the defining voice in the thing, but that each person comes to the table with equal value, because there may be more or less relevance to one treatment strategy in a particular case. So a recommendation about surgical intervention is where most of the surgeons in our group are going to say is we are very sensitive to people telling someone that they are not a surgical candidate when they're, I think Dr. Boudreau will go over the strong evidence that is showing that that is clearly the case. Treatment can be used alone in combination. They are not mutually exclusive, so understanding how they would potentially be used. That could be PRRT and liver-directed therapies. That could be surgery and liver-directed therapies, as long as you understand what the goals of treatment are. Don't hesitate to ask questions about what features of your case go into the treatment recommendations, and keep copies of your records. I think that because neuroendocrine patients will live a long time, and your doctors may retire, they may no longer be among the living, you may move out of state, is that it is actually quite difficult. The electronic medical record is so awesome at being able to get us access to it. It can be so cumbersome because an electronic medical record will literally go over every last thing that's happened to you since you got into the medical record, and it will be thousands upon thousands of pages of records, and really you just want these. You want your pathology, you want operative reports, you want updated imaging and maybe one of the prior imaging. You want maybe 1 or 2 clinic notes. Really, if you're in mine or Boudreau's, you really only need your last clinic note, because we just add everything to our clinic note, so it's like 24 pages long, but everything you would need to know. In Boudreau's case, you even have pictures of all the things that actually are relevant to your case in that same note. And then the molecular testing results, that is one where we will test the tumor for some genetics, and some of the clinical trials and the chemotherapy and immune therapy things are based on that molecular testing. So if you're going to pay for molecular testing, we call that like Caris testing, Foundation 1 testing, Tempest testing, Guardant testing, that's where we're looking at things that are not often utilized in neuroendocrine, but maybe very relevant to you. So if you're paying for it, it's one of those records that you should keep. Excellent. You can email me. I think all of you have my email anyway. Okay, we're going on. Thank you very much.